Merz Aesthetics, a pharmaceutical heritage serving aesthetics. Founded in 1908 by Friedrich Merz, the German pharmaceutical company Merz Pharmaceuticals created its aesthetics division in 2009, Merz Aesthetics. Based on solid pharmaceutical foundations, Merz Aesthetics provides doctors with high-quality aesthetic products that bring out the patient's intrinsic beauty. Beauty has always been at the heart of the company's activities. It was a pioneer in aesthetic and anti-aging care, having developed in 1953 the first anti-wrinkle cream in the world, Placentubes, which was a major advance in the development of anti-aging treatments. Since then, Merz has been internationally renowned for its innovations in cosmetics and aesthetics. Merz Aesthetics has carried out in-depth research, along with dermatologists and plastic surgeons, to develop treatments in line with the skin's natural processes. Merz Aesthetics also aims to provide practitioners with quality medical information and clinical training, a unique service. The company thus supports doctors so that they can better meet patient expectations. Merz's ability to innovate involves anticipating future expectations by working with healthcare professionals in order to provide them with innovative, state-of-the-art technologies. Radiesse, the lifting filler. Radiesse is the lifting filler for a youthful appearance. It provides lifting and contouring effects with long-term collagen stimulation. Radiesse convinces with a triple effect. Versatile filling, volume lifting, and skin rejuvenation ensure a young and natural look. Collagen is the main factor of success in skin treatment strategies. Young skin is characterized by a dense matrix of intact collagen fibers and stretch-activated fibroblasts. In aged skin, fiber fragmentation and reduced density impair the function of the collagen matrix and fibroblast activity. This results in a vicious cycle of structural loss. Radiesse can break this cycle. The degeneration of collagen fibers in the aging skin initiates a vicious cycle of reduced cellular activity, diminished cellular renewal, and decreased protein synthesis. Radiesse acts against loss of structure. It initiates a positive loop of collagen buildup and restores skin integrity by triggering the body's own regenerative capacities. Thanks to its unique mode of action, Radiesse improves the skin in multiple ways. Directly after injection, the gel matrix of Radiesse exerts its versatile filling effect. It effectively fills and improves structural deficits, for results that are directly visible to you and your patients. With time, the gel matrix is being degraded, and the calcium hydroxylapatite microspheres take over. They form a scaffold that provides mechanical stimuli, triggering fibroblasts into producing collagen. Over a period of several weeks and months, a dense network of newly synthesized collagen fibers forms within the skin, providing a lifting and contouring effect. Simultaneously, the calcium hydroxylapatite microspheres are slowly and fully degraded by macrophages. The newly formed collagen network now provides long-term structural support, stimulating collagen production and cell renewal over a prolonged period of time. With 30% of calcium hydroxylapatite microspheres and 70% of aqueous gel carrier, Radiesse has a unique formulation. It is one of the strongest and most uplifting and contouring fillers with a unique stimulatory effect. Radiesse is a state-of-the-art filler with a very high viscosity and elasticity. Its excellent rheological properties define its role as a unique filler for lifting, volumizing, and contouring. The high elasticity of Radiesse confers the advantage of resistance to applied forces, for example, from facial musculature and gravity, for extra stable results. The high viscosity of Radiesse confers the advantage that the filler will tend to remain at the injection site and guarantees great modelling qualities. Clinical studies show that Radiesse effectively improves skin quality on 4 essential levels. In addition to the immediate filling effect, treatment with Radiesse mechanically stimulates the proliferation of dermal cells. Compared to cross-linked hyaluronic acid, cutaneous proliferation is significantly higher following calcium hydroxylapatite injection. Injection of calcium hydroxylapatite microspheres effectively stimulates collagen neogenesis by mechanical action. Within 9 months, a single injection of Radiesse leads to a noticeably denser network of newly formed collagen type 1 compared to hyaluronic acid. As early as 3 months following a first treatment with Radiesse, skin thickness has increased by more than 50% compared to baseline. Radiesse treatment clearly increases the skin's elastin contents. In comparison to hyaluronic acid, administration of Radiesse results in a significantly higher proportion of intact elastin at 9 months following injection. Radiesse is fully biocompatible and biodegradable. The calcium hydroxylapatite microspheres are metabolized through natural mechanisms via phagocytosis. Electron microscopic sections at 6 months demonstrate Radiesse degradation. Microspheres appear to be engulfed by macrophages, and calcium particles are found inside and outside of cells. The released calcium and phosphate ions are identical to the mineral portion of the body. The total duration of the degradation process may vary in individual patients, but full degradation is generally achieved after a few months. Clinical and radiographic findings demonstrate the excellent performance and longevity of Radiesse in vivo. Inside soft tissues, calcium hydroxylapatite supports fibroblastic ingrowth and collagen neogenesis without calcification. The study shows no overt radiographic safety concerns. In long-term computed tomography scans, the appearance of calcium hydroxylapatite diminished significantly due to natural resorption processes. There was no evidence of migration, nor that any osteogenesis occurred. In many subjects, cosmetic corrections persisted to a significant degree even 12 months after implantation, while no calcium hydroxylapatite was visible in 30% of these subjects. Radiesse offers many advantages. It is one of the safest dermal fillers available and proven in numerous clinical studies and scientific publications. A number of 5 million syringes shipped so far is further proof of the great confidence and trust that is being placed in Radiesse. The combination of efficacy and safety is the key to high patient satisfaction. 90% of patients are highly satisfied with Radiesse treatment. Radiesse is a safe and effective filler for lifting, contouring and skin rejuvenation. Its unique triple effect makes Radiesse excellently suited for a wide range of aesthetic indications. Treatments can be individually tailored according to patients' needs. With Radiesse, you achieve long-lasting and natural results that meet the high expectations of your patients. Preventive measures and anesthesia before treatment. The face ages as a result of various phenomena. Thinning and loss of the skin's elasticity Reduction and ptosis of the fatty tissues and changes in muscle tonicity must be taken into account through an overall aesthetic diagnosis and approach. Radiesse injections thus fill in wrinkles, replenish volume, redefine facial contours depending on the indications for the patient. A static and dynamic anatomical analysis is essential for obtaining optimal aesthetic results. The priority is to preserve the natural originality and expressions of each face. Throughout this Radiesse injection demonstration, an anatomical explanation will be correlated to the aging symptom being treated. The Radiesse treatment plan must be explained by the practitioner and agreed by the patient. Certain recommendations are important to respect, as with any filler injection. A complete questionnaire and thorough clinical exam of the area for the injection will allow for the detection of contraindications, whether anti-inflammatories or anticoagulants are taken, or areas that require specific precautions. It is recommended to photograph the patient before the injection and adapt anesthesia to the patient if necessary, local, truncular, as well as to note the doses of the products injected. Anesthesia. Anesthesia means better comfort for the patient and, in turn, the practitioner. Several options can be proposed, especially if the area to be injected is sensitive or several indications are contemplated. Topical anesthesia. Application of a eutectic mixture of local anesthetics which effectively penetrates intact skin. Local anesthetic. Several local anesthetics are currently available. Local infiltration is carried out by a very fine needle and the injection is done slowly. Effective in small quantities, this option should not be used in excessive volumes to reduce tissue distortion. Regional anesthesia is effective anesthesia with low tissue distortion and covering a large zone. The truncal technique must be precise, injecting a small dose of anesthetic directly on the nerve trunk concerned and not on one of its branches. Applying ice is also an easy and safe method of reducing pain. An ice pack wrapped in a towel is applied 2 minutes before the injection without overexposing the skin to cold to prevent burning. These ice packs are also applied at the end of care to reduce edema and hematoma. Marking the face and safety lines. Mark the suborbital limit. If the level on the opposite side is different, lower the upper limit line so that it lines up with the lowest limit. Mark the suborbital foramen. Use a cotton swab to find the subtle depression under the skin. The patient must report any nerve irritation. Trace the line of the medial canthus tendon parallel to the patient's nasolabial fold. The injected product must remain lateral to this line. Mark the lower limit of the cheekbone by tracing a line from the perialar triangle to the tragus. General rule to respect: above this line, administer an injection into the deep dermis and hypodermis and/or an upper periosteal bolus injection, and an upper periosteal and subcutaneous injection to improve the lateral zygoma area in order to connect the areas around it. Below this line, inject into the deep dermis and hypodermis only. Mark the limits of the zygomatic arch. These lines are very important in that the first insertion point must be at the middle of the zygomatic arch. Radiesse injection planes. Radiesse injection with a needle. Radiesse is injected with needles provided in the package or any needle with a caliber greater than or equal to 27 gauge, the most commonly used by linear retrotracing injection process. This injection process involves partially or fully inserting a needle depending on the extent of the indication, while keeping the needle parallel to the skin. The gel is then injected by slowly removing the syringe. With the needle, the Radiesse injection plane range is between the lower dermal and hypodermal layers. Radiesse injection with a cannula. Radiesse is injected with any cannula with a caliber greater than or equal to 27 gauge by a linear retrotracing injection process. The injector makes a pre-hole using a needle. This pre-hole reaches the dermis-hypodermis junction, which will be used to insert the cannula. This cannula is partially or fully inserted depending on the extent of the indication, while remaining parallel with the skin. Just like with the needle, the gel is injected by slowly removing the syringe. With the cannula, the Radiesse injection plane extends from the dermis-hypodermis junction to the hypodermis. Radiesse's retrotracing injection with a needle or cannula is suitable for all common techniques. The fanned technique, which, by changing the direction of the needle or cannula without removing its end from the skin, allows to treat large areas from a single insertion point. The overlapping or sandwich technique, for filling several planes. Or the netting or grid technique, which ensures volume restoration and optimal restructuring. Radiesse can also be injected as a bolus. The ergonomics of the wings and the piston of the Radiesse syringe make it easier to inject and allow for the accurate, homogeneous deposit of the product. Injection techniques. The treatment approach and product selection are in responsibility of the treating physician. Some indication areas shown in this video are not approved according to the IFU. Please refer to the IFU of your country. Temples. The injection in the anterior part of the temple extends between the superolateral orbital edge and the hairline, and then the temporal crest of the zygomatic arch. The crest represents the upper edge of the origin of the temporal muscle. This crest is not very visible in young people. Fat loss and skeletonization create concavity, revealing signs of aging, sometimes to the point of creating an unpleasant-looking ridge at the lateral limit of the forehead. The main anatomical precautions for the injection are the auriculotemporal nerve, which is a deep sensory branch of the mandibular nerve, which goes into the infratemporal fossa and whose main branch extends posteriorly to the injection zone. The frontal branch of the facial nerve, which crosses the fold to be injected. It is located in the superficial temporal membrane. Superficial injections can deposit the filler in very close proximity to this neural branch. Deep injections in the temporal muscle are not made close to the frontal branch. It is very rare that a neural branch is damaged by a fine needle or cannula. The anterior branches of the artery and superficial temporal vein, which pass in front of the tragus and become subcutaneous at the level of the zygomatic arch. The so-called sentinel vein, a branch of the superficial temporal vein associated with the frontal branch of the facial nerve at the supero-external edge of the eyebrow. Medial and deep temporal arteries and veins in the temporal muscle. After disinfecting, make a pre-hole with a needle to the zygomatic arch until the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Sometimes fibrosis can be felt at the temporal crest. If this creates a groove laterally to the crest when the temporal fold has been corrected by injection, it could be useful to use a bolus in this depression. Therefore, it is advised to use precaution to fix this. A few small boluses by needle followed by a massage. Create a fan covering the entire area to be injected, which can then extend beyond the tail of the eyebrow. Note that skin is very thin in this area and the cannula should be inserted very slowly. Do not deposit Radiesse beyond the orbital edge. Sometimes it is necessary to complete the treatment with a bolus in the temporal fossa by very slowly inserting a needle perpendicularly to the bone and injecting a bolus in the supraperiosteum. Cannula injections through the deep temporal membrane and temporal muscle can be painful. Go until hitting the bone. A small aspiration can be made to ensure that it is not in a deep temporal branch. Massage and shape the zone injected to evenly spread the product. A few irregularities may be visible immediately after the injection, but these will disappear fairly quickly. It is recommended that this area be massaged from top to bottom along the muscle fibers. With Radiesse, the result can be assessed immediately after the injection and may vary from patient to patient. Results. The results obtained using the Radiesse injection are as follows when correcting the temples. Jugular groove. In the mid-third of the face, facial aging involves a loss of convexity. Different factors during aging result in the appearance of a depression called the mid-jugal groove. These factors are due to fat, muscle and the septum, and the main factors include the superficial adipose compartment of the nasolabial fold, which does not lose significant volume, the superficial mesial adipose compartments, mid-cheek and deep suborbital, whose fat loss contributes to the appearance of the mid-jugal groove, the orbicular muscle, whose lower edge laterally borders the mid-jugal groove, and lastly, the malar septum, which separates the medial and lateral slopes from this mid-jugal depression. The mid-jugal groove is an anatomical extension, lower and to the outside of the nasojugal groove or tear trough, without the same anatomical etiology. The main anatomic precautions for injecting the mid-jugal region involve the infraorbital artery and the intraorbital nerve, a sensory nerve that starts in the infraorbital foramen of the maxillary bone. Convexity of the mid-third of the face extends to the nasolabial fold below and in front, to the zygomatic arch above and to the back. This full crescent flattens and then becomes concave at its midpoint, highlighting the mid-jugal groove, commonly called the tear trough. Just like with the nasolabial fold, the tear trough has a constant upper end of the nasojugal groove or mid-part of the eye ring, and a variable lower end, depending on physiognomy. Several insertion points are possible for injecting the mid-jugal fold and the associated loss of centrofacial volume. Injections are done throughout the depression area using the fanning technique. The fan extends over the lateral nasal region to the malar eminence while respecting the lower limit of the eye ring. Several fans can be combined. Injections can also be made using adjacent bolus techniques, the pillar technique, when volume loss requires greater projection. The main bolus meets the middle of the tear trough depression, and contiguous boluses are set up based on the physiognomy of the area being treated to ensure harmonious matching with the cheekbone at the back and the lateronasal region at the front. After disinfecting, make a pre-hole with a needle to the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Make the retrotracing injection by removing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the cannula from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. Massage and shape the areas injected to evenly spread the product. With Radiesse, the product deposit and correlated correction are assessed immediately. Several fans can be combined, ending with a netting or grid technique if volume restoration requires it. The tear trough can also be injected using a needle by these same techniques or on adjacent bolus techniques, the pillar technique, when volume loss requires greater projection. Submalar cheek hollows. The posterior jugal fold occurs due to atrophy in the fat compartments of the masseter muscle. On the vertical plane, this fold extends between the zygomatic arch and malar bone at the top, and the mandibular arch at the bottom, and does not correspond to any bony structure. On a horizontal plane, the depression extends from the middle of the cheek, sometimes even at the platysmal cutaneous insertion in the preauricular region, a quasi-fixed structure given the presence of fascia and ligaments. The fat loss in the corresponding fat compartments is associated, to a lesser extent, with the activity of the peribuccal and masticator muscle. A specific anatomical entity is involved in the jugal anatomy. Bichat's fat pad, essentially developed in children and found in the superficial buccinator muscles and deep cheek masseter muscles. The loss of volume in Bichat's fat pad contributes to the sinking of the cheek. The main anatomical precautions for the jugal injection involves the buccal branches of the facial nerve, which extends to the deep anterior limit of the parotid gland, to the superficial peribuccal region and the facial pedicle, which passes in front of Bichat's fat pad. Bordered by the zygomatic arch of the cheekbone at the top and the mandibular line at the bottom, filling the posterior part of the cheek or masseterian fold may be done using many different techniques based on the indication, facial physiognomy, and the patient's wishes. For the most common case, we will choose a netting or grid technique with 2 crossed fans, allowing to fill and smooth out the thinned jugal zone. The first insertion point at the bottom rear meets the mandibular angle and corresponds to this same mandibular point when correcting the facial oval. The lateral fan of the angle rises upward to the lower edge of the zygomatic arch and cheekbone, and forward to the anterior limit of the jugal fold. If the depression needs additional fills and lifts, a second fan can be created, with a high rear insertion point around the lower edge of the zygomatic arch. This second fan is in the direction of the anterior and lower limits of the jugal fold being treated. After disinfecting, make a pre-hole with a needle to the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Make the retrotracing injection by removing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the cannula from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. Massage and shape the areas injected to evenly spread the product. With Radiesse, the product deposit and correlated correction are assessed immediately. Several fans can be combined, resulting in a netting or grid technique if volume restoration of the posterior jugal fold requires it. The results obtained using the Radiesse injection are as follows when restoring volume to the jugal fold. Cheek. The cheek corresponds to the space between the zygomatic arch and the malar bone at the top and the mandibular arch at the bottom. It does not correspond to any bony structure. It extends horizontally from the region next to the nasolabial fold to the preauricular region, which is a basically fixed structure given the presence of fascia and ligaments. Thinning or lipoatrophy of the cheek is the result of the loss and sagging of adipose compartments. Superficial medial cheek fat, superficial middle cheek fat, and lateral temporal cheek fat located further towards the back, associated to a lesser extent with the activity of the peribuccal and masticator muscles. A specific anatomical entity is involved in the jugal anatomy. Bichat's fat pad, essentially developed in children and found in the superficial buccinator muscles and deep cheek masseter muscles. The loss of volume in Bichat's fat pad leads to the hollowing of the cheek. The main anatomical precautions for the jugal injection involves the buccal branches of the facial nerve, which extends from the deep anterior limit of the parotid gland to the superficial peribuccal region, and the facial pedicle, which passes in front of Bichat's fat pad. Bordered by the zygomatic arch of the cheekbone at the top and the mandibular line at the bottom, filling the cheek may be done using many different techniques based on the indication, facial physiognomy, and the patient's wishes. For the most common case, we will choose a netting or grid technique with 2 crossed fans, allowing to fill and smooth out the thinned jugal zone. The first insertion point at the top rear corresponds to the lower edge of the zygomatic arch. Fan provides filling from the lower edge of the zygomatic arch in the direction of the anterior and lower limits of the jugal fold being treated. The second insertion point at the bottom rear corresponds to the mandibular angle. The fan provides complementary filling and sustension of the jugal fold in the direction of the anterior and lower limits of the jugal fold being treated. After disinfecting, make a pre-hole with a needle to the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Make the retrotracing injection by removing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the cannula from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. Massage and shape the areas injected to evenly spread the product. With Radiesse, the product deposit and correlated correction are assessed immediately. Several fans can be combined, ending with a netting or grid technique if volume restoration requires it. Cheekbone. The cheekbone takes up the lateral and upper part of the middle third of the face, a centered relief on a bony structure. The malar eminence, completing the zygomatic arch with its temporal origin, inserting into the masseter and zygomaticus major and minor muscles. The cheekbone is located under the lateral part of the eye ring and outer canthus, laterally to the mid-jugal. Its relief is due to the facial skeleton, but also the malar and deep suborbital adipose compartments in which fat loss and slippage can weaken the cheekbone. Bone resorption only occurs much later. Defect in the physiological development of the bone or insufficient fat explains the frequency of this indication in young people. Trauma is more due to asymmetry. The main anatomic precautions for injecting into the cheekbone is the infraorbital artery and the intraorbital nerve, a sensory nerve that starts in the infraorbital foramen of the maxillary bone. The ideal cheekbone is not too high, not too low, but centered on the relief of the malar bone. It must follow a soft, forward convex curve and continue in line with the midjugal area to the zygomatic arch. During the injection, the needle insertion is high, corresponding to the anterior part of the zygomatic arch, below and outside the outer canthus of the eye. This high insertion ensures optimal anatomical matching with the arch relief. Injections are done in the malar area using a fanning technique, horizontally toward the mid-jugal and respecting the lower limit of the eye ring, expanding downward to an imaginary line linking the alar triangle to the tragus. Injections can also be made using adjacent bolus techniques, the pillar technique, when volume loss requires greater projection. The main bolus meets the summit of the malar eminence, and contiguous boluses are set up based on the physiognomy of the area being treated to ensure a harmonious connection with the zygomatic arch at the back and the centrofacial region at the front. After disinfecting, make a pre-hole with a needle to the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Make the retrotracing injection by removing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the cannula from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. Massage and shape the injected areas to evenly spread the product. With Radiesse, the product, deposit and correlated correction are assessed immediately. The fanning technique can be combined with the sandwich technique on several planes depending on volume restoration required, with the netting technique with a fan starting at the second insertion point slightly lower than the first. The cheekbone can also be injected using a needle by these same techniques or on adjacent bolus techniques, the pillar technique, when volume loss requires greater projection. The results obtained using the Radiesse injection are as follows during cheekbone restoration. Vectors. The human face does not age uniformly. There are fixed areas and mobile areas. Fixed areas of the face, F1 and F3, generally remain in the same position. They work as anchoring points for the skin and muscles through fixed anatomical elements. Superficial temporal and parotid masseter fascia for the metaface, F3, and frontonasal maxillary bone structures for the mesoface, F1. The supportive ligaments also offer additional reinforcement for the face structure. Mobile areas, M2, are located between the fixed areas of the face and are the most affected by the force of gravity. These mobile areas are essentially made up of the fat compartments of the face, which tend to separate, reduce in volume, and gradually sag. The fat loss and ptosis of adipose compartments are associated with the laxity of the skin and distension of the facial ligaments, and cause the face to sag and the appearance of folds and wrinkles. These dynamic and volume changes in the face's anatomical elements can be considered as negative vectors to aging. The physiological vector of aging has a negative direction, since it moves downward and inward, given the mobility of the medial part of each hemiface, which undergoes medial and vertical tissue ptosis. It is also a three-dimensional vector, given the generally associated loss in volume. Changing these negative vectors to the opposite direction, positive vectors, allows replacement of each compartment or anatomical unit at its original position. More than simply filling wrinkles, folds or ptosis, the positive corrective vectors offer lateral and vertical replacement, while repairing the loss of volume and correcting in the three dimensions. This is the medical lift based on three vectors along the following directions. The nasolabial fold, traction of the fold and correction of the malar and suborbital volumes. Marionette lines, traction of line and correction of the anterior jugal volumes. Jowls, traction of jowl and correction of posterior jugal volumes. This technique requires an exhaustive analysis of physiological vectors and face volumes on the part of the practitioner. The indication is more for long, thin faces. A vector has a constant high and lateral anchoring point corresponding to the fixed zone of the zygomatic arch, or just above, and a lower and more medial end which can correspond to three different targets: nasolabial fold, marionette lines, jowls. The vector runs along a guiding line from an anchoring point and toward the middle of the target or the indication to treat. It corresponds to a group of fans of retrotracing lines overlapping at their ends and in variable numbers, depending on the distance between the anchoring point and the target based on physiognomy. The needle or cannula is inserted at the upper end of the vector, at the anchoring point, and injections are made along the length of the guideline using a fanning technique. The second or even the third fan supports one of the branches of the previous fan and follows the same guideline until the target. The nasolabial fold vectors and marionette lines can cross the latter to ensure filling downstream from the indication. This filling is considered gradual. The jowl vector must stop at least 1 centimeter from the mandibular edge to avoid making this fatty mass heavier when depositing the product. After disinfecting, make a pre-hole with the needle to the upper end of the vector until the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Make the retrotracing injection by removing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the cannula from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. The second and third fan, if necessary, take the insertion from one of the retrotracing lines of the previous fan, following the same fanning injection technique along the same injection axis. With Radiesse, the product deposit and correlated correction are assessed immediately. Massage and shape the areas injected to evenly spread the product deposit. The nasolabial fold vectors, marionette lines and jowls can also be injected using the needle using the same techniques. Here are the results obtained using the Radiesse injection along the nasolabial fold vector, the marionette lines vector and the jowls vector. In certain cases, additional treatments may be necessary, depending on the extent of the area to be corrected and the patient's needs. Nasolabial fold. The nasolabial fold is the lateral limit of the peribuccal anatomical unit. It separates the upper perioral segment from the jugal and malar regions and is one of the first signs of facial aging based on a structural process. The fat loss and sagging of mesofacial adipose compartments, particularly the malar and jugal compartments, depend on the nasolabial adipose compartment, which does not lose significant volume. During aging, many tracti prevent these fatty compartments from flowing to the peribuccal region and trap them immediately above the nasolabial fold. The contraction of skin muscles lifting the upper lip, levator alec nasi, zygomaticus major and minor, levator labii superioris, also contributes to the formation of the nasolabial fold. This double component explains the need for a full anatomical evaluation of the middle third of the face, and often a malar and mid-jugal restoration prior to filling the nasolabial fold. The main anatomical precautions for injecting the nasolabial fold are related to the facial pedicle, facial veins and arteries, and its branches, primarily around the perialar triangle. The nasolabial fold has a constant upper end at the anatomical perialar triangle and a variable lower end depending on physiognomy. The needle is inserted at the lower end of the nasolabial fold and injections are made along the length of the fold using a fanning technique. At the same site on the skin, without removing the needle or changing its direction, the fanning technique allows to fill the entire nasolabial fold up to the lateral segment of the upper white lip. After disinfection, insert the needle at the lower end of the nasolabial fold at a 30-degree angle and then change the tilt of the needle to be parallel with the cutaneous plane. Continue inserting the needle into the desired cutaneous plane and then make a retrotracing injection, withdrawing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the needle from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. The fanning technique can be combined with the sandwich technique, depending on the depth of the nasolabial fold. With Radiesse, the product deposit and correlated correction are assessed immediately. Massage and shape the areas injected to evenly spread the product deposit. The nasolabial fold can also be injected using the cannula and the same techniques. The results obtained using the Radiesse injection are as follows in the nasolabial fold. Jawline and mandibular angle. The mandibular line, the rear mandibular angle, marionette lines and the front chin make up the aesthetic anatomical unit of the lower third of the face. This unit develops synchronously, with maximum aging starting at 50 years. The lower maxillary is the bony structure that forms the base of this region. Aging of the lower third of the face is the result of several factors. Contractions of skin muscles. In front, the depressor anguli oris muscle with regard to marionette lines, and the platysma muscle, which is woven with the posterior fibers of the depressor anguli oris. At the back, the masseter muscle, which is minimally affected. Changes in the adjoining fatty layers, in particular the increased volume and sagging of the superficial adipose compartment of the jowl, for which ptosis breaks the mandibular line and aggravates the marionette lines. Lastly, the presence and fixed nature of the mandibular ligament, which produces the mandibular notch and increases the breaking of the line of the oval by dropping the jowls back. These anatomical phenomena are accentuated by other elements: retrogenesis and reduction at the lower face area. The main anatomical precautions of the oval injection concern, in front, the facial pedicle, which enters the region via the submental notch by pre-crossing the mandibular edge, as well as the facial, motor and chin sensory nerve. Pathognomonic of the sagging of the facial tissues and muscular hyperactivity, the breaking of the mandibular line can affect the entire oval or only the anterior part when the mandibular angle remains well defined. The loss of the oval is a frequent indication due to its anatomical reality. When it is complete, the first step in treatment of the back of the jowl is to accurately outline it. The cannula or needle is inserted at the mandibular angle or slightly forward of it if there is a lot of cutaneous laxity. Correcting the posterior segment of the oval is done along the length of the posterior notch, from the mandibular angle to the lower part of the jowl without exceeding its limits in order not to weigh it down. The notch is essentially filled opposite to the inferior face of the mandibular bone, using a tight fanning technique that succinctly rises up the lateral face of the bone to restore the mandibular angle. The second step in treatment may be indicated alone if the oval loss only involves its anterior segment. The filling of the mandibular notch labial commissure triangle by Radiesse allows recovery of the mandibular linearity and the removal of the notch and marionette lines. Clinically, the mandibular notch is bordered by the anterior end, the para-chin, and a posterior end, the jowl. The cannula or needle is inserted at the anterior end of the mandibular notch. The injections are made along the length of the notch opposite the inferior face of the mandibular bone using a tight fanning technique. Then the adjacent lines rise up to connect with the marionette lines by subtending the fold below. After disinfecting, make a pre-hole with a needle across from the mandibular angle point to the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Make the retrotracing injection in the inferior face of the mandibular bone by removing the syringe to obtain a linear and homogeneous Radiesse deposit. Again, opposite the inferior face of the mandibular bone and without removing the end of the cannula from the skin, change its direction and inject as many new lines as needed. Going up along the lateral face of the mandibular angle, the adjacent product lines are fanned out while limiting the number of injection points. Massage and shape the areas injected to evenly spread the product. With Radiesse, the product deposit and correlated correction are assessed immediately. The results obtained using the Radiesse injection are as follows when correcting the jawline and the mandibular angle. Marionette lines. Marionette lines, the anterior mandibular line and the chin, are three anatomical structures located in the antero-inferior part of the face. They evolve synchronously, with maximum aging starting at 50 years. The lower maxillary is the bony structure that forms the base of this region. Aging of the lower part of the face is the result of contraction of the depressor skin muscles and changes in the adjoining fatty layers. Marionette lines are the result of, on the one hand, contraction of the depressor anguli oris muscle, resulting in marionette lines, and of the platysma muscle, which interdigitates in the front with the posterior fibers of the DAO. And on the other, ptosis of the adipose compartment, and more particularly the superficial compartment, which forms the jowls and contributes to the accentuation of marionette lines. These anatomical phenomena are accentuated by other elements: the presence of a fixed ligament, the mandibular ligament, retrogenesis, reduction of the height of the lower facial area. The main anatomical precautions of the injection in marionette lines concern the facial pedicle, which enters the region via the submandibular notch by precrossing the mandibular edge, as well as the facial, motor and chin sensory nerve. Pathognomonic sagging of the facial tissues and muscular hyperactivity, marionette lines, can extend from the labial commissure to the mandibular line. They give the face an appearance of fatigue and sadness and are a frequent indication given their anatomical prevalence. Several techniques can be used depending on the severity of the marionette lines and the physiognomy of the face. We most often choose a netting or grid technique with two crossed fans allowing to fill and provide sustentation for the marionette line depression. The first insertion point is located at the lower tip of the marionette line and the fan is directed upwards. If necessary, a second insertion point is made immediately outside of the marionette line. This fan provides complementary filling and sustentation of the hollow. After disinfection, insert the needle at the lower end of the marionette line at a 30-degree angle, and then change the tilt of the needle to be parallel with the cutaneous plane. Continue inserting the needle into the desired cutaneous plane and then make a retrotracing injection withdrawing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the needle from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. With Radiesse, the product deposit and correlated correction are assessed immediately. Massage and shape the areas injected to evenly spread the product. The marionette line can also be injected using the cannula and the same techniques. The results obtained using the Radiesse injection are as follows when correcting marionette lines. Chin. The chin and anterior mandibular line are supported by a bony structure, chin eminence, then the horizontal portion of the inferior mandibular edge. The importance, or conversely, the unimportance, of this bony eminence characterizes the general physiognomy of the anterior part of the lower face. The aging of this anatomical region is due to insertion of several active muscles, the depressor anguli oris muscle and the platysma muscle, laterally, but especially the mentalis and depressor labii inferioris muscles, which border the chin fold, a real chin septum. The fixity of mandibular ligaments and chin septum, and to a lesser extent from solid muscle insertions, fat loss and sagging of chin fatty compartments. Any reduction in the chin region sagittally or vertically accentuates aging. Any increase in the chin region sagittally or vertically reduces aging. The main anatomical precautions of the oval injection concern the inferior labial coronary artery. If it has a particularly low anatomical variation, facial pedicle laterally as well as the chin sensory nerve. The position of the chin and size of the chin fold affect the physiognomy of the lower third of the face and aging process. In general, and respecting the overall facial structure, the chin is corrected to harmonize proportions vertically by increasing downward and/or profile orthogonalization with a forward projection. Correcting the overlaying chin fold must also always be corrected if it is sunken. Chin eminence is marked off by lateral edges. The needle is inserted in the middle of the first lateral edge and injections are made in the lower half of the chin eminence using a fanning technique. And then the same technique is applied to the other half from the middle of the contralateral edge. At the same point of skin, without removing the needle or changing its direction, the fanning technique allows to project the entire chin forward toward the bottom and fill the chin fold, if necessary. Injections can also be made using a bolus technique, when the loss of volume requires greater projection with a single bolus or two or more boluses in the central part of the chin. These boluses are injected in front of the chin for an anterior projection and in the lower edge of the chin for a downward projection. After disinfecting, make a pre-hole with a needle to the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Make the retrotracing injection by removing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the cannula from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. Massage and shape the areas injected to evenly spread the product. With Radiesse, the product deposit and correlated correction are assessed immediately. The chin can also be injected using a needle by these same techniques or using a single or multiple bolus techniques when volume loss requires greater projection. The results obtained using the Radiesse injection are as follows when correcting chin. Hands. Hands give away age. Along with the face, they are the other part of the body that is uncovered and therefore visible to others. Their surface is highly exposed to aging. Therapeutically, giving back lost volume to the hands is still a little explored area. For the aging of the hand, the most common request is restoring the loss of dorsal volume. To fix this, Radiesse as a biodegradable injection is the benchmark for this indication. The hand has 3 layers, separated by 3 sets of fascia. The thickness of the superficial fatty layer, which varies with age. The intermediate layer, containing the arteries and sensory nerves. The main nerves of the hand are the median nerve, the radial nerve, and the cubital nerve. 2 main arteries of the hand are the radial artery on the outside and the cubital artery on the inside. The deep dorsal layer of the hand, which includes the extensor tendons as well as the muscles of the fingers and wrist. The tendons, which circulate in the hand, are the endings of the extrinsic and intrinsic muscles of the hand. The flexor tendons, for the most part, pass through a canal on the anterior of the wrist. It is recommended that Radiesse be placed in the intermediate layer to avoid damaging the tendons and prevent the product from migrating. The needle technique is a bolus technique. It is done using the 28-gauge needle provided with Radiesse. Identify through the skin the vascular structures and tendons in the hand of the patient and determine the 4 points for injecting these boluses. Position them in each of the intermetacarpal spaces at approximately 1 centimeter below the joints. After complete and careful disinfection of the hand, define the points of entry. Lift up the skin using the thumb and index finger and then inject boluses of 0.2 to 0.5 cubic centimeters of Radiesse under the fascia. Thoroughly shape the Radiesse so that the product is spread throughout the back of the hand using a hydrating cream. Diluting Radiesse may facilitate its injection and distribution. Cannula may limit the post-op complications of needles. Moreover, larger surfaces for injections and long tracks are done from a single entry point. Cannula injections are less traumatic, accurate, and relatively easy. Make the point of entry at the carpal bone. This single point is generally enough. It is best to use a long 25-gauge cannula to cover the entire surface of the hand. If necessary, plan to have a second point of entry. Then, make 3 or 4 retrotracks. The volume injected by retrotrack is approximately 0.2 to 0.4 cubic centimeters, and the average total volume of Radiesse is about 1.5 cubic centimeters for both hands. Some practitioners prefer to dilute Radiesse to facilitate the injection and the spreading out of the product. Radiesse has an immediate effect. Its opacity conceals the veins and fills in the intermetacarpal spaces. Radiesse treatment in the hands is not recommended for patients who have had their axillary lymph glands removed. The patient should not carry heavy objects after the intervention. Edema may appear 2 to 3 weeks after the injection, but this is temporary. A second treatment can be carried out 2 to 3 months after the first one. The results obtained using the Radiesse injection are as follows when correcting hands. Post-therapeutic steps. Disinfect the area after any injection. Massage and shape the areas injected to evenly spread the product, and photograph the patient after the injection. If necessary, a touch-up can be carried out during a checkup to have optimal results. Respect the minimum time period of 7 days. The used or partially used syringes and needles must be considered infectious medical waste. The syringe contents are for one-time use on a single patient. Since each treatment is specific, tell the patient about the precautions to take after treatment. In general, the following are useful tips. In the hours following the injection, the patient must not touch, handle or palpate the treated area. However, you can ask the patient to massage the area in certain cases. Local reactions, redness, edema, numbness, could occur after any injection. These reactions may last a few days. Ask the patient to report if these reactions persist more than a week or the appearance of any other side effect as soon as possible. Regular skincare habits and makeup are possible a few hours after or the next day after the treatment. In the days following the injection, the patient must not expose themselves to sun or intense heat, UV, sauna, hammam, etc., over a long period of time in the few weeks following the injection. A few days are required to assess the final result. This is the time needed for the product to settle, for potential edema to disappear, and for tissues to regain their suppleness.